95% of asymmetries are dental velar. 95% of asymmetries are easily managed with tooth movements after expansion.
So welcome to our fourth live event. My name is Patrick from Get Expanded, and I hope you're all having a wonderful evening. If you're new here, welcome. Our mission at Get Expanded is simple. We aim to bridge the gap between patients and providers so that we can have an open, non-biased conversation about airway health, jaw development, and expansion. Whether you're currently in treatment, considering treatment, or just wanting to learn from leading experts, you're in the right place. So tonight, we're honored to have Dr. Svitlana Koval with us again for a deep dive into managing asymmetries during skeletal expansion. For anyone joining for the first time, Dr. Koval is an airway orthodontist, widely known for her MARPE face protocol, and she treats patients from all around the world out of her office in Boca Raton. As always, at the end of the presentation, we'll open up the floor for a live Q&A. Feel free to raise your hand and ask questions live, or you can drop a question as a message and we'll get to as many as we can. So now, without further ado, Dr. Koval, last call you spoke about understanding asymmetries, and today is kind of like this part 2, managing asymmetries. If you'd like, why don't you start by telling us the key takeaway of today's presentation, and the floor is yours.
Thank you, Patrick. Thank you for having me here tonight. And thank you, everyone, for joining us. And to those, cheers to those who will join us during this recorded session available on YouTube after. We will be talking about management of asymmetries and how to address those pre-existing asymmetries and the asymmetries that may or may not arise during the expansion itself. We're all terrified with the very word of asymmetry. We think that that's almost the end of the world when talking about the expansion. So we'll learn more what that means, what can be done for that, to address that, and what are the main ways of addressing the pre-existing and arising asymmetries. Again, a disclaimer, I don't have any monetary compensation for this presentation, and the information I present here is a product of my own experience and exercising these techniques in my practice every single day. This practice that I work at is dental sleep medicine practice, and we focus on airway orthodontics. So we use orthodontic biomechanics and this novel approach of facial expansion with different appliances that can be basically applicable to children starting 3 and up, and to adults with, I would say, no age limit. So we have a very vast experience in using this technique, and this is basically what we do every single day, 9 to 5. Sometimes it's 10 to 6. But this is the only thing we do. We do expand, and we use different kind of expanders, and we do research on the basis of our practice. We analyze those cases, and we publish that research to be available for all other providers worldwide. So I will start with the main kind of parts of this presentation. We will be talking about the causes, again, a little bit of a classification about the actual real life patient cases. We'll talk about the strategies. We'll dive just a teeny bit, not to bore you too much, into the literature. We'll have conclusions. And of course, our favorite part is the Q&A session. So what I would start with, and you can appreciate the picture I have put here, the asymmetries, while they are of the greatest concern for those considering facial expansion with any type of technique, it has to be clearly understood that some asymmetries are not impactful, even though they're present and recognized. Meaning that not all we're not scared of all and every asymmetry there is. Asymmetries could be impactful and non-impactful, meaning that some asymmetries, they do exist, they can be easily recognized, and they cause aesthetic and functional discomfort. They affect our quality of life to some extent. Some other asymmetries, even though they exist, they might not be fully recognized. So they exist, but they're hidden, and they might not even show themselves or reveal themselves during the expansion. So they are there, but they will not show in any way. And that's why they're considered non-impactful. So if we're talking about the impactful asymmetries, those that pre-exist and impact quality of life, for example, existing facial asymmetries associated with existing TMJ, jaw deviation and opening, clicking, popping, jaw tension, pain, occasional jaw locking, headaches, and migraines. So that is considered impactful asymmetry. And some of the patients that approach us in our practice, they say, hey, I do have my TMJ/TMD, some sort of a disorder. And will it really benefit from that MARPE or FME expansion? And will it hurt me? Will it make my condition worse? Or sometimes patients, when they don't even consider any sort of expansion, they come to our practice and say, hey, I do have this clicking joint, I do have this sore muscles, I do have a lot of pain and tension when I open my mouth, or even just regular headaches. So what that means, if this condition is related to the bite, to the asymmetry, which is located within the bite itself, yes, of course, this TMJ condition, TMD condition will be alleviated, might be almost healed and cured with this treatment, because what we're doing here with expansion, with midfacial expansion, we're evening out those forces that cause asymmetrical muscle loads. So for those patients who doubt the, I would say, efficacy of midfacial expansion for their TMJ, TMD reasons, if your condition is related to the musculoskeletal and occlusal relationships, not to the, I would say, derangement within the joint itself, saying that, hey, there is a disc displacement or there is some bone pathology within the joints. So if this is just purely muscular and occlusal, yes, this treatment, midfacial expansion, will greatly improve and will even out those loads that contribute to asymmetrical pain distribution in the face. Group B of impactful asymmetries is related to those that are pre-existing and may impact expansion itself. For example, they may be recognized before we even plan that expansion, while we do the consultation and we talk to the patient and we discuss their CBCT findings, and we look at those structures that are very closely related to the maxilla and to the midfacial expansion. So we all know that, for example, orbits are composed of the maxillary bone, and they're composed, one of the walls is composed of the zygomatic wall, and again, the maxillary wall. So several walls are composed of those bones that are directly involved in midfacial expansion. So if we're looking at those structures, patients sometimes ask, hey, if this is what I do have, will it get worse? So talking about the orbital asymmetry, and again, this is a little bit of a literature review. Every literature shows us that even within one skull, even within one single patient, there is an asymmetry in their orbital size, and that asymmetry could be as much as 0.8 milliliters of volume between the left and right sides. And there is a high discrepancy or high range of different sizes and volumetric measurements between orbits in different humans and different patients. So even though there might be some asymmetries between two sides before the treatment, these asymmetries may not show themselves during the treatment. They may remain hidden during the treatment, but they may also show somehow within the treatment or during the treatment. Because if there is a pre-existing asymmetry, we just need to talk about this. We need to recognize it, and we need to tell that this might be related not to some aesthetic concerns, but to some functional changes during the treatment. For example, moving bones within during the expansion itself may or may not cause some discomfort when those bones separate, because bones, when they separate, when the sutures become mobile, then it might show itself as a little bit of a inflammation, is a little bit of bruising, a little, might be a little bit of a bleeding, like in inside, and that causes that puffiness, inflammation, some soreness. But these are all uh, temporary effects. But we need to understand that this might happen. It's not something which is not curable. It's not something permanent. It's just the reaction, and of course, it depends on the on an individual. Um, uh, I would say. Features of the patient. It also depends on the type of the device, on the design of that device, and on the mechanism of activation of that particular device. Non-impactful asymmetries, those asymmetries that arise during the expansion, most of the time, the majority of patients, they say, hey, we have expanded the top. Now I have noticed that there is a new asymmetry I've never noticed before. So my bottom jaw has moved to one of the sides. This is a temporary, I would say, shift that happens because both jaws are expanded at different speed, and because the mechanism of expansion of the top and the bottom, it differs a lot. So when we start our treatment, we do start with expanding the top, and we do start expanding the bottom almost simultaneously, because bottom expansion via remodeling and via tooth movements, that takes way more time, and that may temporarily cause mandibular shifting, the shifting of the lower jaw to either side, to, I would say, a preferred patient's side, just to maintain some degree of, I would say, conventional or habitual chewing, just to maintain those um, preferred ways of digesting and chewing food. So these asymmetries are not impactful, and these asymmetries, we all need to understand that this is just a temporary effect of expansion, and it will be changed, it will be corrected. Sometimes it's even preferable that we do see the shift in the mandibular position, because when we do have a lot of constriction within the upper jaw, when we begin with this asymmetrical phase, this is what happens with the bottom jaw, that starts realigning itself, and it starts looking for a more aligned, for a more relaxed position, and it starts shifting to the opposite side because muscles feel more range of motion, muscles feel less restriction, dictated by tooth positions and dictated by the upper jaw position, to realign that mandible relative to the neck, relative to the facial midline, and relative to the TMJ condylar eminences. So just to make a little bit of a picture, I have pulled out this movie here. This is a time lapse of the real patient in our practice. What it shows is that when we start actually expanding, you see there is a diastema happening, and then we do see that the top is way wider, and the bottom is not fully engaging. There is no perfect cusp fossa contact in the back, and then we keep expanding, and then we keep advancing the mandible, and now you can appreciate that these contacts, they become tighter. The further we move through the treatment, the better the contacts become, the more, I would say, the better quality they achieve. So this is just how the treatment works, and this is how the bite works. We have to first increase the size of the maxilla in order to realign the mandible, and then we will be doing some adjustments for the mandible. We will be doing advancements, we will be doing expansion, and then we will be locking that new bite in a more advanced and a more expanded position. So we need time, we need some space first. And the mandible is always, I would say, compare it to a little doggy moving around and running around the backyard, and it's limited by the fence. So the top jaw is the fence, and the backyard is the range of motion for the mandible while we're expanding the top, or once we have expanded the top. So this is one of the articles we just recently published, and I mentioned that during our last presentation. So this article addresses a case report of a patient where we have actually develop that asymmetry during the expansion process itself. So we used 3D guided piezokeratotomy in this patient, just like we always do with all our patients, with all our adult patients. But why I'm bringing up this particular case report is because it's interesting to understand what factors may potentially impact and may kind of lead to that asymmetry. The biggest takeaway is that no matter what happens, it's all correctable. So it's easy to correct any sort of dental velar asymmetry that happens with any type of treatment here. So what I would say becomes more challenging is fractures that Dr. Manuel was talking about. But asymmetries, to the most part, they are mostly, again, dental velar, and I will keep emphasizing this throughout my lecture, throughout this presentation. Most of the asymmetries are dental velar. They are related to some sort of bending, or they're related to some sort of initial asymmetric position of the teeth within their sockets, or relative to the vertical part of the alveolar process, or some sort of canting, and most of them are corrected with tooth movements following the expansion. So I want to just bring your attention to some factors that may potentially contribute to the developing of the asymmetry while we're doing our expansion. And these factors are just the pre-existing dental velar asymmetry, maxillary arch asymmetry, meaning that sometimes teeth of the left and right sides of the same arch, they may be positioned slightly within a slight range, I would say, anteriorly, posteriorly. So let's say canines of the right and the left side. One canine might be positioned slightly more forward, slightly more anteriorly compared to the other side. And that also brings some asymmetry to the tooth movements, to how we position our appliance, to how we apply forces, and to how those forces are being redistributed between those teeth. So we also take into consideration root positions. Now we'll be talking in more detail a little bit later about this point. It's suture position and orientation. I'll be also diving a little bit deeper into the anatomy of our hard palate, and of course appliance design and positioning. There is a QR code here on this particular slide, and you can look up this article. It's available. It has an open access. So the question is, what if I have an asymmetry? What's next? Is this the end of the world? Not all asymmetries are equally concerning. Even though there is the same word, there is the same nomenclature, they are all called asymmetries, but not all of them are impactful enough, or some of them are not impactful at all. This is the case presented in the article, and again, I've created this time lapse here. So this is the patient. We put her MARPE expander. We did piezokeratotomy. We started expanding her, and if you see with expansion, her left side, which is kind of on the right side of this video, it kind of moves a little bit more forward compared to the other side. So we do have this asymmetry that happens not between the right and the left side in a transverse plane way, but we do see that this migration of the teeth happens in the anterior posterior plane. So the teeth of the anterior quadrant on one side and on the left side, it moves more forward compared to the anterior quadrant on the opposite side. When I started analyzing this case, I needed to know, does this asymmetry happen in all planes of space? What planes of space are actually involved in this kind of asymmetry? And when I understand what planes are involved, what dimensions are involved, I start analyzing those factors that could have potentially contributed to this situation. So when I'm looking at the palate from the back view, from this kind of transverse cross section, I want to see if there's anything happening to the back teeth, if there's any change in inclination. Why did this happen? Again, a little bit of a time lapse. So here I don't see any changes. I don't see any changes to the palatal architecture, to the palatal wall. I don't see any changes in the transverse plane. So this plane kind of, I cross it off and see that there was nothing happening with this particular plane of space. I then started analyzing my patient from the frontal view. So this is, again, this is another animation. This is another time lapse when we took the CBCT scans and we superimposed these CBCT scans during each stage of this patient's treatment. And this blue CBCT scan, this blue mesh, stands for the initial position and the initial relationships, and all teeth are marked. This is how we analyze our cases, and you see that we do have those red dots that are positioned to mark and to trace certain structures, and we trace teeth, and this is how we analyze our cases in 3D. Because 2D analysis, lateral cephalometric ceph analysis cannot give us all the information to plan our cases and to analyze them once expansion has occurred. So let's look at this. And you see those lines, the kind of, some of them are parallel, true parallel, some of them are not. So the dark red line symbolizes is just the cant of the maxillary plane. I wanted to understand if those teeth, if they move vertically, just based on those lines that we put here, the red line, which is the line of the canine position, the vertical canine position, the midfacial plane, and so I want to see, did my alveolar process actually move down on the same side, on the left side? So I kind of crossed out any transverse discrepancies. It didn't happen in the transverse plane. So it's not the transverse plane that was involved. Now I want to see if this is a frontal plane that was involved. Where did my bone with all of the teeth move? What happened? So here you see, and I'm just kind of following that red line that connects the dots of the canine incisal edges, and it actually becomes even a little bit kind of more parallel. So it was not related to the vertical movement of that alveolar process. And this is just a superimposition between the blue, which is pre-expansion, beige is the post-expansion, and pink is something that is the actual CBCT that we took after the expansion and after our asymmetry correction. So you do see that there is an expansion in the transverse plane, but I don't see any changes in the vertical plane. Now I started analyzing the same patient in a different plane. So I look at this patient from down to top. So we call this an axial plane, axial projection. Now I want to see, I isolated this particular movement in one plane. And what you can notice here is that, again, here on the beige superimposition, there is a very there's a very obvious movement of the left side of the alveolar process of the upper arch forward. It becomes wider and it goes way more forward compared to the opposite side. So this is what happened. Now I'm wondering why this happened. So what happened here, there was no transverse movement, there was no vertical movement. It just moved nicely in a parallel fashion forward. That's it. Why did this happen? Why did I notice this fullness of the outer part of the alveolar process in this patient? So I started diving deeper into the initial positions of the teeth, of the roots. And what I've noticed is that this patient did have some microdontic teeth, meaning that some teeth were not the same size, the same shape as the rest of her teeth. She had several teeth missing. And when I did slices of her roots of the maxillary arch at different levels, I found that on the left side, the same side that I was observing the asymmetry, the roots were positioned closer to the outer surface of the bone. So I could feel more proximity and I could see more proximity of those roots closer to the outer surface of the bone. And now this is the progress of the same patient. You can clearly see that with MARPE expansion, even though the forces were redistributed in a parallel fashion, I engaged canines to second molars. We do see that the left side moved slightly more, and it was something that was related to the root positions as well. So what happened here? There is an anatomy of the mid palatal and of the hard palate, and I'm pretty sure that You all are familiar with this. So there is not one suture in the within the hard palate. There are two sutures, and they're located kind of crisscross. The hard palate is composed of four distinct bones. Two bones are the palatal process of the maxillary bone, of the kind of the bone that makes this whole midfacial part. And the very back of the hard palate is two horizontal plates of the palatine bone. So there are two other bones that are attached to the maxillary bones uh, via so-called transverse suture. So when we do mid-palatal expansion, we anticipate that the palatal process of the maxillary bone and the horizontal part of that palatine bone on the same side, they behave as one unit, as one. Same thing on the other side. So we do separate it as a cake. So we kind of cut this mid palate in the middle, and we separate, we just distract those two halves, thinking of it as two distinct parts, while each of them is composed of two subparts, right? So it's the palatal process of the maxillary bone, and it's the palatine process, it's the horizontal process of the palatine bone. So what we don't want to think of, if that mid palatal of if that I'm sorry transverse suture separates, we're not anticipating, we're not aiming at that mid transverse suture to actually separate. So what happened in this patient, we achieved a really nice parallel separation of the mid-palatal suture, but then her transverse suture on one side, it separated to a higher degree, to a greater degree than the same suture on the opposite side. And we kind of reached this L-shaped separation with the transverse suture separation on this left side and a nice and parallel separation of the mid-palatal suture. So that's why this anterior quadrant, anterior segment of the hard palate on the left side moved more, just because of that separation. Another thing, again, I kind of go down and I break down that analysis of the same patient, because I wanted to isolate all the, I would say, covariates, all the factors that have contributed to that asymmetry. I don't want to isolate only one and apply that particular rule to every single patient, but I need to understand what is the variety of factors that might be involved. So first, we isolated this mid-palatal / transverse suture separation. We also isolated the position of the roots. And here, I want to bring your attention to the position of the upper incisors. This is a very important point. And again, I want to emphasize this a lot. I do see this in patients who have undergone extraction of upper premolars, and where spaces were closed with retraction mechanics. So in these patients, we do see frequently that their upper incisors, central incisors, and lateral incisors have a negative root torque, meaning that the roots of their upper incisors, of their maxillary incisors, are closer to the buccal bone, and they are positioned mostly vertical, just like on a image D on this slide. So if you see a tooth which is positioned almost vertical, and when you consider midfacial expansion, you may anticipate, and this is like a little rule of thumb, you may anticipate that there will be a differential movement of this tooth compared to the tooth or the central incisor on the opposite side. Sometimes, and we do see this in the practice, we do see that after separation, one tooth moves slightly more down, kind of vertically down, compared to the same tooth on the opposite side. It's not related to the vertical asymmetry, or in a very rare percentage of cases, in a very small percentage of cases, it's related to the vertical asymmetry or a vertical drop of the of one of those processes. It's mostly related to the position of the tooth, and it's very much associated with this root proximity to the buccal plate of the bone. So you do see here, I have put pictures, a kind of transverse not the transverse, but the sagittal slices at the level of the two upper incisors, two central incisors, two lateral incisors, showing that each tooth has a different inclination. Each tooth has a different angle to the maxillary plane, to the plane of the ANS, PNS. We all have this notion that once we see teeth nicely aligned, they're all positioned within the bone in the same fashion, they have the same angulation. It's not the case. Every single tooth has their own range of root torque or root movement, and there is no single tooth which is positioned at the exact same angle compared to the other one. So again, now I'm taking this a little further, and now I'm showing you what happened after we expanded. So this is the sequence with expansion. This is the sequence when we kept expanding, when the asymmetry started actually showing itself. And this is, and you can clearly see there is this asymmetry, but then we started redistributing those spaces. We started moving teeth, and you see how the arches nicely developed, and that asymmetry was completely corrected with just tooth redistributions and tooth movements. And I'm playing this again and again. I'm looping this video just to show you that tooth movements, they reshape the alveolar processes that are that kind of embed those teeth, and we see a way better outcome with just moving teeth after the expansion. And you can see it here as well. So that's just to illustrate how moving teeth improved that asymmetry that occurred with the expansion and with some asymmetrical anterior movement of this alveolar process on the left side of the patient. And this is what happened. So our treatment was focused on not only redistributing, but also reshaping this alveolar process. And once we move teeth, once we kind of drag those roots within the bony envelope, we're dragging new bone. We're dragging new bone, and we're reshaping the outer surface of that bone. Again, doing this carefully. What happens when we want to reshape it? We just play, or we just move the roots inside the bone to bring this bone in the direction that we need. So what happened here, we pre-programmed our aligners, and I'm working a lot with the shape memory aligners in our practice. We do have the software where I directly design and plan those aligners. We print them for our patients, and we find this particular technique very efficient in moving teeth. I would say very, very effectively. We don't do braces in our practice. We work solely with aligners combined with midfacial expansion, with custom MARPE, MSE, FME, and with expanders that we use in kids. So these are the outcomes. What happened is that we calculated the initial inclination before expansion. What happened also, we did improve the inclination with our direct aligners, and that inclination was increased by 9 degrees, by 1 degree, by 6 degrees, thus changing the fullness, changing the shape, changing the outline of that alveolar process caused by the asymmetry that occurred during the expansion itself. So again, this is the outcome, and this is the axial projection of the same patient, and we see that there's asymmetry with the beige mesh, and then the pink mesh, that is the last one. You see that this asymmetry is corrected by the movements with direct glandular aligners. This is one of the patients that we have expanded by 11 millimeters, the mid-facial, the mid-palatal separation of approximately 11 millimeters. This is how I measure and calculate those expansion. I rarely use intermolar width or interpremolar width as a success rate of my expansion. I always measure this mid-palatal separation. What MARPE and FME does, that creates the movement in this patient, and in with the separation, with the midfacial expansion, with the axis of rotation around the frontozygomatic suture. So we do see that the maxillary zygomatic suture, it moves outward. We do see that the whole midface moves outward, and we do see that there is a little bit of a movement where the zygomatic arch is attached to the temporal bone, but most of the movement happens within the zygomatic maxillary suture, between the fronta zygomatic suture, of course, between the nasal bones and the fronta maxillary attachment as well. Of course, which is not seen here, which is not visible here. We do have a lot of movement with this amount of separation in the area of the pterygomaxillary sutures. And with what we've noticed here and what we've measured with the superimpositions of the skulls with this degree of expansion is that once we expand to the degree of 10 millimeters of mid-palatal separation, then we do see up to 3-4 millimeters of forward movement of the whole midface. Again, this is another factor that I would like to point your attention at is the positioning of the mid-palatal screw, of the position of the actual screw that produces that expansion. So the position, why this matters and which are the structures that we are focusing at, of course, it's the positions of the teeth, it's the interradicular tabs, and it's also the location of that transverse suture. So if the if this screw, if the tiger screw, or if the with FME, there is way less, or I would say approaching zero chance that the suture, that the screwing mechanism, that the expansion mechanism is somehow distorted, because it's a very careful planning and it completely relates on the bone structures, and it's very carefully pre-planned with all the guides that are used during the positioning of the appliance. But when we are tied, or when we are using teeth as a part of the anchorage with these appliances, it's important to keep the orientation of that expansion mechanism nice and parallel to the transverse suture itself. So the transverse suture, and again, it's a very schematic image here, which kind of does not stick to the actual proportions and the scaling of how things are interrelated in real life and real world, but just an idea. The transverse suture is located behind those second molars. It may have a little bit acuter degree, sharper degree of angle between this mid-palatal suture and the sides of the transverse suture, but as a general rule, it's located behind the second molars, could be somewhat at the level of the second molars. If the expansion mechanism is not completely parallel to that suture, we can anticipate a different lever arms, different length that may contribute to that forward movement. This is what actually happened in this patient. So just a couple words, and you know that there are different designs of the appliances, and we mostly, so we have audience from all over the world here. And thank you, Patrick and Jean Paul, for having us all here and being able to share European techniques, American techniques, Australian techniques from every single country that can be used. And one of the mostly widespread techniques is, of course, the MSE technique. And this article by Morgan, it names it MARPE, but we know that this is the appliance that was introduced by Dr. Von Moon, and it had several generations of this appliance. And generation one used a little bit faster protocol of activation, where Dr. Moon suggested that 4 to 5 turns should be made during the same activation, while MSE2 delivered smaller forces and the amount of activation was slower. That's why this term of slow palatal expander arose. So now we do see that the more, I would say, aggressive the activation is, the more pressure, the more stress is put along those areas, and especially the area of the mid-palatal suture. And if you look at the picture of the figure 4 on the left side of the slide, so you can see that the degree of expansion, the more we go, the further we go into this expansion, into this separation, the more stress is accumulated within certain areas. So you see that this the figure 4 on the left side of the slide shows that with a degree of 0.25, there's very small degree of stress allocation around this mid-palatal suture and around the area where the expander is located. With the 3 millimeters of expansion, there is more stress redistributed along those areas, and with 5.81 millimeters, there's way more stress, and we can clearly see that this red area is separated by something, which is the transverse suture, obviously, and there's another area which is kind of leaning towards those pterygomaxillary sutures, towards the pterygoid plates. So we know that the higher the expansion, the higher the degree of expansion, the more stress is redistributed further towards the pterygomaxillary suture and towards the back, where we are aiming at that separation, where we're aiming at that kind of forward movement of the whole midface. So now when we're looking at the right side of the picture, this is the stress distribution with the MSE2 appliance, where we see less space, less stress redistributed at the same degree of activation, or even at higher degree of activation. And we do see that we still achieve a lot of that we still achieve the same pattern of stress allocation, aiming at separation of that pterygomaxillary suture, but at a higher degree of activation. So it's a kind of gentler way to distribute forces. And this is the same, this is the comparison of two different types of appliances, the modified MSE and the one which we called, which is just bone-borne MARPE appliance. And they show, so again, they show the difference between the tooth bone-borne appliance and the purely bone-borne appliance when we do not engage any teeth into the design of the appliance. Again, with the tooth bone-borne appliance, we will see that the stress is redistributed, and we can see this red line, which shows us just the visualization. It's the finite element analysis, when it's just a simulation of the forces that may arise during the expansion process itself. So we see that it highly depends. The forces are concentrated in the area of the location of the appliance, of the mechanism, of the expansion mechanism itself, and also, of course, where the appliance is attached to the teeth. So the further the appliance is positioned towards the back of the palate, kind of the closer it is to the pterygomaxillary suture, and the higher chances that this produces this separation and the forward movement. This is just one of the cases that shows us the easy way to correct pre-existing dental velar asymmetry. And we need to understand that those things have to be spoken of and discussed prior to any treatment. And it highly depends on the initial head posture and the initial head position. And I have shown you during my previous presentation that depending on how I position my head, the evaluation of the symmetry of my face will be different. And again, the patient may present with the habitual kind of bending of their head towards one side, but once we realign this, we can see that the asymmetries that were hidden just by the head bending, they show up when we realign that head. And because with this treatment, with the midfacial expansion treatment, we clearly see, and in I would say 95% of cases, that head posture is improved, forward head posture is improved. We see a lot of postural improvements with just aligning the mandible against the maxilla or increasing the size of the maxilla, just to allow the alignment of those mandibular arches, faces, masticatory muscles, the muscles that are engaged in the same kinetic chains related to the masticatory muscle. So we do see a lot of alignment with just expansion, with just a couple months of midfacial expansion. Now I'm just moving forward with this case, and what we see when we realign the face and the head of this patient, we see that her smile is not actually aligned. So when she bends her head, it looks like it's parallel to the floor, to the perfect horizontal line. But once we realign it, once we realign it with the actual horizontal plane, we see that the left side of her smile, the left side of her upper arch, is slightly lower compared to the right side. And this is what our patient noted. After expansion, we still see that the left side is a little bit lower. And you can clearly see that we did not even need to realign her head after expansion. It's positioned nicely and straight against her neck, even though it's slightly kind of moved parallel to one side, but it's aligned and it's not bent anymore because of the expansion. Now, the smile alignment was achieved with a liner movement, with a liner biomechanics. The way we did this, it just shows us how the alignment was achieved, just to show that the left side was a little bit lower on the top picture, and on the bottom picture we see nice smile line following the curvature of the lower lip. Here is just a part of the biomechanics. Again, when you come for the consultation or once you are in treatment, all tooth movements or all dental velar movements are easily corrected, and usually providers do not correct them before they start expansion because they will have to correct it after expansion anyway. So there is no point in moving teeth before we do expand, because we will engage those teeth in some way, or those teeth might have those micro movements, physiologic movements during the expansion just due to forces of mastication. So we will, in most of the times, again, I'm not saying in 100% of cases, but most of the times, in the majority of cases, we will do this correction after the expansion is done. Here's the patient that we expanded by, again, 10 millimeters of mid-palatal separation. This patient did have this excessive gingival display, like more obvious gummy smile on the left side. And this became even more obvious after the expansion, just because the sides, the teeth were pushed out, and it increased the size of the smile and the width of the smile. So what happens here, again, same thing. The left side is slightly lower, but what happened here with the liner movements, and again, at this stage, the patient was still at the during this treatment. You can clearly see that between that picture and this picture, the maxillary plane was corrected. The teeth on the left side were corrected, and the gingival display was significantly reduced on the left side. Here, and with the canine, with having nice parallel smile, with just the liner movements, with no TEDs, with no additional mini screws here. This patient is the same patient, is how we plan our direct printed aligners. We do have this software that I personally pre-plan, pre-program to move teeth according to the face, according to how these models are related to the skull. We use CBCTs, we upload CBCTs, we upload intraoral scans to merge them together and to plan those tooth movements relative to the smile, relative to the face. So again, you can clearly see that mandible has some sort of cant, and some teeth are moved up. So we do extrusion on the upper arch. We do have a lot of extrusion, pre-existing extrusion on the left side, and that is being moved to where that is being moved up just to align those the smile line, to align the position of the lip, the upper lip, lower lip, and the smile line of the teeth. This is just, I would say, a nice illustration of how different, in different situations, mid-palatal expansion happens. And you do see that the amounts of expansion here are pretty decent. So the average expansion in our practice for a female patient is between 4.5 to 5.5. For the male patient, we usually go a little bit higher. It could be anywhere from 7 to 8. In some cases, patients specifically ask me for wider expansion for different reasons. But you do see that regardless of the amount of expansion, or I would say to some degree, but depending on the initial position of the teeth, they behave in a different way. They behave differently depending on how their roots were positioned prior to the expansion. And again, it's another illustration of those cases. And you can see in some cases, patients or teeth, they open up in a perfectly parallel fashion, while in other cases we can clearly see some distinct vertical steps between the upper right and left incisors on both sides. So every midfacial expansion opens up differently. There are multiple factors contributing to that: prior orthodontic treatment, individual positions of the teeth. Even with the absence of the prior orthodontic treatment, teeth by definition may be positioned in a different way. Our faces develop gradually, and the way the face is developed is highly dependent on the surrounding functional structures, including the tongue, including the cheeks, including the position of our arches, again including the position of the head relative to the neck, and the head and neck relative to the rest of the body. So once the baby is born, there are no so-called TMJ condylar heads. So the TMJ presents itself flat. There is no fossa. There is no condylar head. With teeth erupting, and especially with the upper central incisors erupting, this anatomy becomes more distinct, becomes more accentuated. Um, there are schools that work on, and there are books, many books that were published on the relationship between how upper maxillary incisors are positioned and what is the anatomy, what is the steepness of that TMJ anatomy related to those upper incisor position. So the steeper is the angle, the steeper the angle would be within the TMJ itself. So we need to understand that teeth will erupt, not because they're supposed to erupt in this particular spot, but teeth will erupt to the position of the opposite arch. And mandibular and maxillary teeth will erupt to meet each other, to create the point of the best and the widest contact, depending on how the jaw itself is positioned. So the jaw basis may be positioned in the most disadvantageous way. They may be positioned in a so-called skeletal class 2 relationship, while the teeth, sensing that position, having this position as a baseline position for a long period of time, will erupt towards each other and will lock themselves in a perfect class 1. So why does this happen? Because teeth erupt to meet each other to create stability and balance, regardless of the jaw position. These two things, dental class and skeletal class, unfortunately, are not related. 95% of asymmetries are dental velar. 95% of asymmetries are easily managed with tooth movements after expansion. And again, it's just two little things, two little examples of how we usually correct. We use TADs for this purpose. Sometimes we do need TADs. Sometimes we engage those TADs with elastics, with aligners. Sometimes we just use aligners, just as I showed you. And this is one of the examples on the lower arch when I do move the teeth of my patients with the software that we use, and when we plan jaw movements, and when we lock that jaw position with the coordinated, with the focused and targeted tooth movements. Again, this is how we do. We can use aligners, we can use elastics, we can use TADs, and we can just use direct printed aligners here, pre-programmed to the face, to the skeleton, to the neck position. And this is our website, and this is it just shows that you can always find our newest research that is published, and we do have open access to all of the articles that we publish here. As a conclusion to this presentation, asymmetries are the most discussed topic when considering midfacial expansion, and appliances that are pure bone-borne, just like FME, create no impact on posterior teeth. And they reduce dental velar flaring of premolars and on molars depending on how the framework is designed. Both designs, tooth bone-borne and purely bone-borne, may impact anterior teeth, indirectly though. Asymmetries are impactful and non-impactful. Again, they may present, they may happen, but do they matter? Will they impact function? Will they impact aesthetics? Will they somehow impact our appearance and quality of life? This is what matters. There are patients for whom tiny little changes matter. There are patients that do not notice them. How impactful. We cannot assume that all asymmetries are the same, and what matters is that how they impact our quality of life. Non-impactful asymmetries are those pre-existing and those related to midfacial expansion. 95% of asymmetries are dental, alveolar, and easily corrected. I just want to reassure you here that in my practice, doing these treatments every single day from 9 to 5, from 10 to 6, all the asymmetries arise from tooth movements, which is easily correctable and which are reversible. And it's the topic that Dr. Manuel presented that matters. So this is what we want to avoid. We want to avoid the fractures. Thank you very much, JP and Patrick, for having me today. This is the last slide for this presentation, and I'm available for the question and answers.
Perfect. Thank you so much for this amazing presentation. That was very thorough. And I gotta say, I think most of us enjoyed the crazy frog music in the background. That definitely took us back. So now we're gonna start the live Q&A.
I would say this is a very extreme example, but that's a really cool question. It's called ultramech, yeah, alternating turns. So we do start turning in one direction, then we reverse it. It's provider's preference, and I would say this may be a good thing to consider if there is a lot of restriction in the sutures. Sometimes the palate is so narrow that it's almost impossible to position the appliance closest to the center of resistance of the maxilla. I am not using this particular protocol in my practice. I do see a lot of success with the 3D guided mid-palatal piezokeratotomy, which has completely eliminated any need for alternating turns and for loosening those sutures. We do see that this 3D guided mid-palatal piezokeratotomy approach, it highly reduces any fractures because we redistribute that pressure, those loads, that concentration of pressure from the maxillary zygomatic sutures, which are I would say, the most frequent site of fractures, the other sides. So I would say that I have seen some restrictions to mid-palatal separation with the appliance design, with very, very severe maxillary constrictions, with some bending of the appliance. But I don't think that this vast or this huge discrepancy between expanding and constricting is necessary, or is somehow, I mean, it's not what we're looking for. We are looking at doing probably one turn forward, 2 turns forward, and then 1 turn backward, but just to loosen up those sutures. Again, it depends on the provider's technique, and in our approach, there is no need to implement that, just because we don't anticipate this sort of limitations with the treatment. But that's a great question. The question here, and it's I would say a lot of times patient ask this question, and the topic of the face mask is very highly discussed, widely discussed. So with the premolar extractions, there are several reasons to extract premolars. In most of the cases, it's class 2 malocclusions. Sometimes it's class 3 malocclusions. So it depends. We need to understand what was the initial and what is the current jaw-base arrangement. If this patient does have the remaining skeletal class 2 with the maxillary position, with the S and A angle approaching 90 degrees, 90, there is no point in using any face mask. So that retraction is not related to the position of the base itself, but it's related to the dental velar deformation and the retraction of the alveoli and this vertical part of the maxilla. So retractive mechanics, it kind of pulls maxillary arch and the dental alveoli backwards with the teeth. And that's why we do see that those roots, they kind of move and they distort towards the buccal plate. So not in all cases, in an ideal world, it's not supposed to happen, but sometimes we call it a loss of anchorage, so that's why that happens. Again, face mask is not the universal solution to all facial protraction. What I've seen that with 10 millimeters of expansion, with 11 millimeters of mid-palatal separation, we were able to achieve 4 millimeters of forward movement of the whole mid face, with even 3 months of the face mask use. So we don't need the whole year of face mask use. Why this matters? Because it matters when you start disengaging those sutures, when you continue expanding, when you kind of pull those sutures apart, and you want to maintain that. So once you have pulled that mid-face forward, what holds that position in place is the bite. So you don't need any external appliance to hold that position in place, because it behaves like a bone in a sack of made of muscles and ligaments, and it's kind of balanced against the lower jaw. So we still have this maxillary suture maturation during the next anywhere from 6 to, I would say, even 12 months after we concluded our expansion. But the stability of that expansion highly depends on the position of the mandible, and of course the absence of any external forces, unwanted forces. So that forward movement is achievable, that can be done, but do you really need this? A very thorough analysis need to be performed before any I would say request comes from the patient. Hey, I need this face mask. You not always need that face mask. Sometimes the problem is with the dental alveoli, with the alveolar processes, not the maxillary position. Very good question. Very frequently asked. Again, I want to refer back to my favorite topic of 3D piezo. Why? Because the reason we have come up with this approach is that the midline that you see on the palate is not necessarily the midline of your actual bony palate. They do not coincide in most of the cases. And what may seem like this soft tissue midline, it might not be the position of the nasal septum, it might not be the position of the actual bone, of the actual suture itself. So if you are looking on your palate from down to top, and if you're looking at the roof of your mouth, what you see as unevenness between the right and the left side could be an impact of your tooth inclinations, could be an impact of the initial position of your teeth, and even in the absence of the posterior crossbite, unilateral, bilateral, no matter what, it can still be the case, because what I just emphasized is that when we develop, our teeth may erupt in completely, I would say, irrational positions, just because they want to stabilize our bite. So one side, teeth on one side may be more upright compared to the other. That's why that other side will be a little bit flared and will look a little bit wider, while the other side might be a little bit kind of tucked in or more upright. So when we evaluate the size of the palate, we're not looking at the teeth. We never look from the underneath. We look at the CBCT. And those mid-palatal separation is always the reciprocal movement, meaning that we do expand and we do push against two surfaces, against two halves of the bone, in a simplistical way, away from each other. We can come up with some sort of a differential movement, but is this really what we need? I don't think so. So what is happening here is that the analysis needs to be done to understand why do we actually see that asymmetry from the bottom, kind of looking, visualizing the roof of our mouth. And most of the times it comes from the positions of the teeth. With the face mask, yes, of course. We all understand that it's just simple logics that more force is applied. Again, the degree of movement, the direction of movement, it depends. And I cannot advise on any specific range of force, because most of the times, or I would say in some cases, this force might be differential. So sometimes there is a pre-existing slight asymmetry between between the right and the left side, and we want to put a little bit more traction on one side compared to the other. It is related to the position of the anterior part of the nasal septum, and maybe to the position of, like, the fullness, the proximity of the outer wall of the maxillary sinus. So most of the times, if we're applying forces with a face mask, they have to be differential. They depend on the stage. We do not jump into high forces right away. We gradually increase that force. It may be sensitive for one patient, it may be less sensitive to another patient. Again, sometimes this separation of the nasal bones slash maxillary frontomaxillary suture, it happens at a different pace. Sometimes the activation of the appliance differs from patient to patient, again, depending on the appliance that we're talking about, if that is FME, if this is MARPE. So what is the mechanism of activation? How wide? Most of the times that depends on how wide patient can open. And a patient with I would say, more restrictive opening, with 35 millimeters of opening, the degree of activation of appliance will be different compared to the patient who opens 55 millimeters. So that's how it depends. And again, you have to consult your provider. I highly advise all of our patients, please, please, please talk to your provider. Ask all those questions, because you are like no other. It's your specific case. It's your individual anatomy. It's your individual bone response. It's your individual body response. It's your life. We cannot put the same patterns, and we cannot implement the same way we expand everyone. Everyone is different. That's why everybody who comes here to this practice, we talk to them. We see which factors potentially can contribute to this expansion. Sometimes it's more sensitive for one patient. Sometimes they're afraid to open their mouth too wide because they have a history of some jaw locking or TMJ pain. So it highly depends. And I believe that it's not appropriate here to give any advice on any forces. This is a good question. You can definitely use a face mask. And you can use there used to be a crane neck collar, and we have recently contacted them, and they no longer sell those products. They may exist somewhere. I don't know, maybe somebody's just reselling their own appliance, or I just what I currently see here on the market is that we have regular face masks, which I don't personally like too much, and we do see those face bows that rest against the chest, which is very bulky and I would say very uncomfortable. In my experience, this crane device was very, I would say, more humane than anything else, and you could use it while sleeping and even while kind of doing some chores around the house. But again, you can do that. You can also, again, those chewing exercises. This is a great force application, and redistributing those forces with applying applying additional forces to your chewing apparatus. Mewing will not be so much helpful, just because we have stolen some space from the tongue, and with the appliance itself. But I would say the most efficient and predictable way would be to use some sort of external force during the early stages of activation, starting from the very first turn and up to the stage to where the expansion is complete, probably a little bit beyond that, maybe a couple of weeks. Again, in my experience, I do not suggest kind of torturing yourself beyond that uh, beyond that time, beyond the time of completion of expansion, just because at that point we're looking at actually settling those sutures and using the bite as this stabilization for that newly achieved position of the maxilla. But you can also achieve additional fullness to your midface, again, depending on what structures you're superimposing, depending on if you're superimposing at the level of the nasal bone, not frontal bone, but nasal bone, maxillary base, nose itself. So depending on what structures you're most interested in, if you're looking to achieve some additional, I would say, kind of protraction in the area of the maxilla, just tooth movements with the alveolar remodeling, those movements that I showed with aligners, with just moving roots around and remodeling that bone will also help a lot with the protrusion. If you're talking about just simple lip fullness, just like we do with regular tooth movements, the more you play with the inclination, with the forward backward movement of your incisors, with the proximity of those crowns, the fuller lips you get. So it also depends on what area we're more focused on. So when we apply forces to the midfacial complex, we understand that the forces are applied to the appliance, right? So the point of force application is some connection in the area of the appliance. And what we're actually moving, we're moving the appliance attached to the midface. Midface, which is basically the maxillary bone on each side. So midface is composed of two maxillary bones. Again, with just superimpositions and with just those animations, what happens is that once we expand the jaw, once we expand the midfacial complex more, and once we go beyond a certain threshold of that expansion, what happens is there a natural forward and outward movement of the whole midface with what just happens with squeezing out of that structure from within the restrictions made or composed by the positions of the zygomatic bones. So imagine this zygomatic and maxillary sutures loosening the space between the zygomatic arch and the maxillary suture, it increases, and the maxillary bone, it increases, and the whole midface is just being brought forward by the volumetric, by the ballooning, by the expanding force going from within that just brings it forward naturally. Again, it highly depends on where and which sutures will be separating. Of course, orbits are involved, but to a lesser degree. There is some movement around we call it inferior orbital rim, and also the superior orbital rim, just because we have a proximity of the temporal bone and the zygomatic temporal junction. But we do see some movement, and we have to be not cautious, but just to understand that all these structures are involved. Very good question. With the unilateral crossbite, what happens, and that this is a pattern, is that on the side of the crossbite, the vertical height of the maxilla is smaller. Maxilla is shorter on that side compared to the other side. The chin is always shifted to the side of the crossbite. The mandible is kind of torqued to the side of the crossbite, and the teeth will be flared on the side of the crossbite. So there are certain patterns that accompany this unilateral crossbite. There will be a cant of the maxillary plane every time there is a unilateral crossbite, every single time. So we're not talking here about the unilateral or bilateral expansion. We are talking about reversing those compensations that occurred during our or somebody's body's compensating for this crossbite, because crossbite potentially what it contributes to the lesser surface area where when mandible lands against the maxilla. So in order to kind of compensate for that, uh, maxillary teeth flare. Maxillary teeth increase its inclination that looks like wider one side compared to the other side. So what needs to be addressed here is after expansion, because bone expands reciprocally. Bone does not sense if the teeth are positioned in one way or the other. Bone just expands. But what happens to the teeth is the matter of the proper treatment planning. So that has to be discussed in advance, because we will see that one side kinda expanded more than the other. It's not true, because the bone expanded evenly. Bone just pushed, one side pushed against the other. There is no higher or bigger or smaller expansion on one side, but the teeth inclinations that have to be corrected are differential. They're different. So going back to the question where if the nose is tilted, again, on the underdeveloped side, on the side where there is the unilateral crossbite, the maxilla itself will be a little bit more flat. It will be the maxillary sinus will be smaller in volume, and the nose tip could be also pointing at the side of the asymmetry, at the side of the deficiency. So once that expansion happens and once teeth are moved, usually what we see that the nasal septum kind of realigns a little bit. We see this a lot with children, because what happens there, the A and S point, it separates. It's no longer one single point. It's no longer one attachment, bony attachment. It becomes two separate attachments to the soft tissues, to the cartilage that makes this anterior portion of the nasal septum. So that allows for the anterior portion of that nasal septum and tip of the nose to realign. Again, it's not the very purpose of that expansion on this presentation, but it's just a clinical observation. Again, great question. In my experience is that there is a certain threshold of expansion when you do anticipate that this actually happened. And again, we do conduct our studies to see what actually happens and what are the covariates here, what are the factors involved in this process. But what was shown in other studies is that a certain degree of expansion contributes more to the actual separation of the pytergomaxillary sutures. It depends on the gender of the patient. It depends on the age of the patient. It highly depends on the technique. Either there is any sort of corticotomy, piezocorticotomy, or any sort of loosening or auxiliary procedure to the mid-palatal suture or not. So again, it's the origin of the asymmetry that we're talking about. Where is it coming from? Is it from so congenital? It could be crossbites, might not be necessarily congenital. It's also part of it. Could be from any previous, I would say, interventions. Could be even from fillers, Botox. It could be from differential function. So that is the most frequent non-congenital aesthetic asymmetry coming from masseter muscles. If there is one favorite side where the patient prefers to chew on, we will see a greater development of that angle of the mandible. I would say not rounder, but a more distinct angle, fuller, more pronounced masseter muscles. We can even see temporalis muscles more pronounced on that side. It highly depends on the malocclusion. And we all understand that arches, that certain chewing muscles are responsible for the quadrants of our arches and how our bite comes together. This affects the involvement and the activity of certain chewing muscles, especially muscles responsible for closing the jaw. So we do have two major groups of muscles that are responsible for closing movements or for static opening closing movements. It's closing movements. It's temporal muscles and masseter muscles. And these muscles are also highly involved in clenching. So depending on the involvement of those muscles and the preferred side and the arrangement, the occlusal arrangement, we might see those. So for these particular purposes, MARPE itself will not be like for muscular origin asymmetries. MARPE itself will not be the direct way of solving, even though it's a huge part of solving this problem, because if a patient clenches on one side, it means that the bite is uneven. It means that the pressure is distributed for certain reasons unilaterally or not evenly. So one group of muscles is involved more. In class 3 malocclusions, we will see more involvement of masseter muscles with less degree of temporal muscles, because all the group function and functional movements are mostly controlled by the posterior teeth, opposingly to, let's say, class 1 malocclusion, where we do see that canines are more involved. This is the preferable scheme. So if this is a neuromuscular occlusal origin, then it will be corrected with rearranging occlusion after realignment of jaw bases. I hope this answered your question. Great question. We can differentiate. We can. I do advise that your provider does that. But as a general rule, forces can be directed upward and, of course, forward. Forces can be directed downward if there is some severe maxillary impaction, if there is no adequate incisal show and we want to move that maxilla downward. Again, we're conducting a study right now where we're examining the rotation of the maxillary plane, and what we're seeing, this is our preliminary data, it's not the general rule that maxillary plane is rotating downward. It does not happen in every single case. So this notion is based on previous studies that used lateral cephalometric x-rays, and we understand that the lateral cephalometric x-ray, it's a superimposition of two sides, and it also depends on how the patient head is positioned, even though it is positioned with a cephalostat, but it may still have some degree of asymmetry. So once that, the biggest thing here, the biggest takeaway here is that any evaluation of the post-expansion position of the ANS is very, very vague, because that ANS separates in two. And it is very, very difficult, extremely difficult to position a patient in such a way that those two ANSs after expansion, they kind of coincide in one point. There's always like a trade between the NS position, cephalostatic patient positioning, depending on what we're looking for. And also that nasion point, that all the downward movements were generally calculated so that nasion point separates, and the nasion and the nasal bone moves downward. So how do we measure this? There are multiple studies that have different opinions on that. Again, my personal conclusion is that not every single patient undergoes downward movement of the midface, and we are in the process of publishing our next article, which I hope we'll see in a couple of weeks, that shows that in class 3 patient, in a male patient, we did see a lot of upward and counterclockwise rotation of the maxillary plane, and that was measured with a 3D CBCT superimposition, not with a lateral cephalometric X-ray. So with the kind of higher in-depth technology, we can evaluate the same things from a different angle, and I believe we will come up with different conclusions just based on the available technology and the treatment planning and analysis software.
Well, that concludes our live call today, and I think this went really well. Thank you so much, Dr. Koval.
Thank you.
Amazing. And I'll take the time now to announce that we'll also have our next call, correct? Which will be December 22nd on a Monday, around the same time, right?
Correct. Yes, and we'll be talking about obstructive sleep apnea and MARPE FME treatment.
Okay, perfect. Well then, we'll see you all there, hopefully. And until next time.
Thank you very much, everyone, for joining us. Thank you, JP. Thank you, Patrick.